Okay, good morning, everybody. I apologize that you can't see my video. Having some technical issues in that regard, but is my voice coming through okay for you all? If anyone could just type in the chat saying, yes, we can hear you. Perfect. Thank you, Mohsin. So just to introduce myself, my name is Emyr Bakker, and I'm a lecturer in medical sciences at the University of Central Lancashire. Today's session, we're going to have a little taster session and a little taster lesson about medical terminology and also an introduction to physiology. We're then going to talk about a physician associate and what a physician associate is. And we will then cover why you should become a PA, because let's face it, it's one of the best careers out there. So I'm going to just be moving through the slides and popping into the chat occasionally. So this session, as we said, is going to be an introduction to medical language, terminology, and physiology. So I'd like you to put your hands up or just put in the chat about if this has happened to you. Have you ever read a scientific textbook, read 3 sentences and not really taken it in, or paused because you had to understand the words? For me, my brain goes blank a lot of the time, so I'm going to put in the chat that it's happened to me. And same for Shambhavi, same for Mohsin. Lovely. So really, the reason why that happens when you see these big, chunky scientific textbooks is that science and medicine, they have their own language, okay? And without understanding how that language works, it makes it infinitely harder to understand the content. However, the fact of the matter is, scientists, clinicians, we like to sound cleverer than we are. So we like to use these large words that really sound intelligent, but are actually pretty simple when you break them down. So if you can understand the common parts of medical and scientific words, then you can understand words that you've never seen before. And that's what we're going to have a taster for here now. So medical words will always sound complex until you break it down. So imagine that you're in clinic and someone comes running down the corridor saying, help, we have a patient who has tachycardia, glycosuria, and polycythemia. What do we do? Some of you may have looked at that sentence and thought, what on earth do any of those words mean? But let's break it down. So you can see here, we have a couple of tables. And what these are prefixes or suffixes to different words that are important for medicine. So you may have heard before, for example, of hepatitis. So hepa is related to the liver and itis is related to inflammation. So hepatitis would be liver inflammation, for example. So you can combine these words and really start to understand what medicine is and what these words mean. As an example, let's have a look at these 3 words: cytosol, intercostal, and glycosuria. In the chat, could you please paste what the definition of those words are using these tables? And I will award a free physician associate degree to anybody who answers a full word. So Shambhavi has said inter, between. Cytosol is cell solution. And Mohsin has said between the ribs. What about glycosuria? Do we have any takers? Well done, Mahi. And Mohsin has said glucose in the urine. Awesome. You all get physician associate degrees. That's pretty much all you need to do medicine, I'm sure. My colleague may disagree with me, however. So next up, we've got cytosol and intercostal and glycosuria. You were able to break down the meaning of those words. Now, I want you to create the words for these. And I gave away the answer for one of them earlier on. So what would making new glucose be? So Harish has said glycogenesis, and Mahi has said glyco or glucogenesis. You're both very, very close. But what's the new in there? There we go, Mohsin. Thank you. Gluconeogenesis. So that's specifically making new glucose. And that's important because when it comes to studying the physician associate degree, you'll be learning all about the biochemistry of the cell, and you'll learn about the compensatory metabolic pathways that the cell has. And there's a difference between making glucose and making new glucose. What about liver inflammation? I gave this one away. There we go. Thank you, Mahi. So that's hepatitis. And material in cells is, as we said, cytoplasm. So well done. You're starting to think and understand words like a scientist. These words all sound really, really complicated. But actually, if you break it down, they're pretty simple. So if we go back to our previous thing, we had tachycardia. So tachy is fast. Cardia is related to the heart. So that's a fast heart rate. Glycosuria, as we said, is glucose in the urine. Polycythemia, let's break that down. So poly is many. Cyte or cyto is cells, and emyr is blood. So that just means many blood cells. So you can see, if you start to break these words down, then they really become more understandable. Now I have a challenge for you all. Think of a silly yet logically consistent word. Okay? So for example, I have dermophobia. I am scared of skin. What else can you think of that's silly, but actually makes linguistic sense? Chocophilia. I definitely have chocophilia, as you can attest, Jane, from the chocolate stash in my drawer at work. Maluriogenesis. So, but the creation of bad urine. I like that, Harish. I like the creativity. So, if you, like I say, it's a bit of fun to play around with these words and understand them. And for me, once I finished my degrees and I'd started learning more about medicine, it was really interesting to actually just understand the nomenclature that they use in medical TV shows, for example, because a lot of the time it's actually correct. And, you know, if you watch a show like Scrubs or Grey's Anatomy, they're actually pretty medically accurate to some degree. To some degree. Lovely. So another silly but consistent word is this one. She's running away from something. She's scared. And what she's scared of is red. So she has erythrophobia because she's scared of red things. But understanding medical terminology is completely essential to understanding medicine and physiology. It makes your life infinitely easier if you're able to understand these scientific words. And the key concept in physiology is homeostasis. So homeostasis is defined as the maintenance of a relatively constant internal environment despite changes to the external environment. Your external environment includes things like the ambient conditions, the present or absence of food and drink, and also your levels of exercise, which in turn cause excess and demands. The parts of your internal environment that are maintained by homeostasis are core temperature, blood osmolarity, blood pH, and blood glucose level. And if any of you have ever been to the doctors, which I'm sure you unfortunately have had to go to the doctors in the past, they'll take your blood, for example, and often they'll measure things in the blood in order to get an understanding of your homeostasis. What we have here are the normal ranges for blood values, and we call these reference ranges, which means that these are the values that you should be within for a healthy individual. A question I have for you guys, and again, feel free to post it in the chat. Is the reference range for people the same, or does it vary? Okay, so Marley has said it varies, as does Shambhavi and Miriam and Isabel. You are all correct. So these reference ranges will change based on certain characteristics. So Miriam very rightly says that this is based on age. What other factors do you think can influence a reference range? Age is one of them. So Isabel is saying weight. Now, that doesn't really change what your reference range is, because the reference range is where you are if you're healthy. So the weight will influence what your values are, for example, for the sodium in your blood and things like that, as will the diet. But they don't change what your reference range should be. So health conditions and illnesses, diet and weight, they change your values that you actually get when you read the blood, but they don't change what they should be if you're a healthy individual. Because that illness is how, that change when they're different is how we define the illness and associate it. So what other factors? So it was very rightly pointed out about age. What about gender, for example? That's one. Men and women have different reference ranges for certain aspects. And yes, thank you for that clarification, Jane. And the other thing is ethnicity. So there are a number of factors that influence these reference ranges. So whenever you take any kind of test at the doctor's office, or the PA's office, I should say as well, they're going to compare your values to the basal values. And that gives them an understanding of your homeostasis. So why is homeostasis so important? So I have a very serious question for all of you, and this will determine whether you can get into physician associate school or not. Have any of you ever fried an egg? Okay, Marley, congratulations. That criteria is what lets you get into physician associate school. So yes, the reason why homeostasis is important is because we need to maintain the key aspects of our body. And if you imagine that you're frying an egg, you start off with this beautiful, clear liquid. And as you heat it up, it undergoes changes due to the heat and then solidifies. So in the case of the egg, you start off with the albumin protein. And when you heat it up, it denatures. And as it cools, it gets novel cross-linking. And that changes the egg irreversibly. It's exactly the same thing when it comes to the enzymes within our cells. So if we have changes to the conditions within our cell, so pH, temperature, and so on, this can cause irreversible damage to our proteins. And that means that important proteins within the cells, such as your enzymes, receptors, and transport proteins, might not be able to carry out their function. And if you have a change to their function, that threatens the life of the cell, which in turn threatens the life of the tissue, then the organ, the system, and then eventually the person. Okay? So understanding homeostasis is crucial and fundamental to the entirety of medicine. So you will have heard of homeostasis before, I'm sure. So you start in a homeostatic state, and you then have a change that causes a loss of homeostasis. There will be attempts then to compensate for that change. If compensation is adequate, then your health is maintained. If the compensation is inadequate, then you're at a health risk. So obviously, there are a number of things that will promote your homeostasis. Will require homeostasis. So it's a constantly ongoing process in your body. But one in particular thing that really homeostasis has to really act upon is when you do physical activity. So for example, if you do physical activity, a particularly strenuous activity, you will get increased use of oxygen. You'll get increased production of carbon dioxide. There'll be increased production of lactic acid and an increased production of heat. Normally, delivering this session live to a classroom in person, I would be cruel and get a volunteer to stand up and run around the classroom to demonstrate all of this. If you want to run around your living rooms or wherever you are now, feel free. But it's very true that all of this happens. So if you have an increased use of oxygen, then your body's going to be in trouble if it doesn't respond and compensate. So if you have too little oxygen available for essential aerobic reactions, you're in trouble. If you have increased production of carbon dioxide and increased production of lactic acid, the acidic conditions could affect your enzymes. And if you have increased production of heat and you don't compensate for it, then you'll have increased body temperature, which again could affect your enzymes. So in order to compensate for this, the body increases the depth and rate of breathing. And on the wrong thing here. It increases the rate and depth of breathing. You'll get increased circulation of the blood through increased heart rate and stroke volume. You'll get vasodilation of the skin and vasodilation in your muscles. So all of these are crucial for compensating for the body's response. And as a clinician, if you're trained to be a physician associate or a medical doctor or a nurse, there are a number of measurements that you can take to measure homeostasis. So you could look at the blood pressure. Is the blood circulating at a high enough pressure to reach all parts of the body? Or is it too high, which could potentially damage your blood vessels? You could look at the blood levels of the ions, the amount of blood cells that you have, your hormone levels, and so on. And you can also look at what are called ABGs, or arterial blood gases. You could look at a core temperature. You could look at an ECG, or an echocardiogram, and that will show you the heart rate and rhythm. And most commonly, or one of the most common ones, is urinalysis. You can look at urine. You can find out a shocking amount of information about somebody by looking at their urine. And if you're trained to become a clinician, it will be your life. So have fun with that. So now we've got a little case study. And we're going to be looking at a patient who has been previously diagnosed with type 1 diabetes. And they're brought into the emergency department in a semi-conscious state. So there are a few things that may flag up in your mind when you see this. You know they're diabetic and they're semi-conscious. So what is your first gut instinct when you see diabetes and unconscious? Okay, so Miriam is saying to check blood sugar levels, and Isabel is saying that there's a lack of glucose in the blood. So you're thinking then that they have hypoglycemia. Hypo is low, glyc is sugar, emia, blood. So hypoglycemia. So in order to understand what's going on with our patient, we have to do a few biochemical tests. So let's have a look at what happens. First, we'll look at their blood pressure. And paradoxically, it's high. Which is really strange because, as we said, we think that what's going on is they've got hypoglycemia, low blood sugar. If they have low blood sugar, you'd expect their blood pressure to be low, not high. So what's going on? Next up, we take their body temperature. This is normal, so we can't get any clues from that. Next up, we look at their urine volume, and they are reporting that they have frequent high-volume urine. I'm sure you are all aware, but one of the primary symptoms of diabetes is frequent urination. So we kind of expect that with our patient. Next up, we're looking at their urine glucose level. Now, normally, you shouldn't have any glucose in your urine. So if you detect any above like a very low basal limit, then it's considered high glucose in the urine. So we've got high glucose in our urine. It's a very unusual patient that we've got. Lastly, we check their blood glucose level, which was what Miriam suggested to do much earlier on. And their blood glucose is actually high. So what on earth is happening? All of these tests are actually indicating that our patient is hyperglycemic. So how does all of this arise? So what this comes down to is that our patient has not been taking their insulin, okay? Which means their glucose has gone out of control. So again, I have another very serious question that will determine whether you get into physician associate school or the UCLan School of Medicine. Have any of you ever eaten syrup before? So Marley says yes, Isabel says yep, and it's great. And if you've ever had Canadian maple syrup, it's the best. Okay, so Jane has said in the chat that with regard to homeostasis, you need to gather the information on a number of what are called vital signs, and you'll learn all about these vital signs when it comes to university. So blood pressure, temperature, urinalysis, blood tests, and so on, to get a full assessment of the patient. Because if we had just assumed that the unconscious diabetic patient was hypoglycemic and given them sugar, we would have made them worse. So therefore, you need to do a full assessment and be very careful. Now, I asked you about syrup because, one, everyone loves syrup, and two, is the simple fact that syrup has a number of properties. And among these are the fact that it's sticky and quite difficult to say. It's not as, what's the word I'm looking for? It's sticky and it would be hard to pump around, okay? And it's the same sort of thing if you have lots of sugar in your blood. I'm not saying that your blood becomes syrupy. Don't eat a lot of sugar and then taste your blood. Wouldn't recommend it. But if you have a lot of blood in your sugar, it makes it harder for it to pump around. And therefore, that's why we're seeing this high blood pressure, because the heart is really, really trying to push that sticky blood around because it's so full of sugar. So that explains the high blood pressure. The frequent urination, we see that simply because we know it's a common symptom of diabetes. But the high glucose in the urine, that is because the body is trying its best to flush out all of this excess glucose that's in the blood. And therefore we see the glucose in the urine. So the actual solution for this is that our patient simply needs insulin. But this demonstrates the importance of assessing homeostasis quite well. Because if you don't assess homeostasis, and if we had just assumed that they were hypoglycemic, we would have made them worse. But congratulations, you've all treated your first patient, which is a good milestone. So the second half of the presentation now is we're going to be talking about the physician associate degree and a little bit about the School of Medicine at UCLan. What I just gave you was a sample taster lesson And actually, that forms the first part of the physiology content that you'll get if you study with us, because it's a very good way to get an understanding of the body. But now we'll be talking about MPAS. So, at UCLan School of Medicine, we have 4 degree programs. Well, we have more, but these are the main ones that we consider for undergraduate entry. So, we have our Integrated Masters in Physician Associate Studies. We have the Bachelor of Medicine, Bachelor of Surgery, BSc Medical Sciences, and also BSc Medical Sciences Foundation entry. And we're talking about the Physician Associate Studies course. In terms of our campus sites, we have campuses in Preston, West Lakes near Whitehaven in Cumbria, and also in Burnley. If you're studying directly on the 4-year undergraduate physician associate course, you'll be based in Preston. If you study the postgraduate physician associate course, you can either do it at Preston or in Cumbria. And lastly, if you do come on the foundation year as a route to train to become a physician associate, you spend your first year in Burnley if you're a UK student. UCLan also has a campus in Cyprus, and I keep petitioning my boss to let me go and work in Cyprus for the sun, but unfortunately that request has not been approved yet, so I'm stuck in lovely old England. Okay, I just got a notification saying I was muted. Can you all hear me? Okay. Okay, lovely. Thank you, Jane. So, on the bottom left, you can see the physician associate students in the West Lakes campus. So physician associates are defined by these lovely burgundy scrubs, although some of my colleagues like to refer to them as a wine-coloured scrub. Either way, they are beautiful, and that will be your uniform when you're out on placements in years 3 and 4. On the bottom right, you see our clinical skills suite, and that's where we train you up in clinical skills. And you can see that everybody's wearing face masks with the exception of one gentleman at the back. But this picture was actually taken pre-COVID because we were just getting people trained on PPE, which is very relevant in the current times. We also have a number of facilities available at the School of Medicine. So this is our anatomy room. And the anatomy room is a slightly horrifying room for someone like me. I'm a molecular person, but anatomy scares me. But it's a very, very cool room because you get to really look and play with these anatomy models. And that gives you a really good understanding of practical anatomy. And we also have here our Anatomage Table. Now, this is one of my favorite things at the school. You can think of this as essentially a big iPad. But instead of getting apps and playing Flappy Bird or whatever the current apps are on the iPhone, this is all about understanding the human body. So again, I'm going to ask a question, and if you could pop it in the chat, that would be appreciated. Does anybody know what a cadaver is? And if so, could you let me know what it is? So Shambhavi has said dead body, Miriam has said dead person, and you're both exactly right. A cadaver is a dead body that's been donated to medical schools or medical training institutions to allow students to perform dissection. One benefit of us being a new medical school, because we've only just got our accreditation now from the GMC, although we've been running our PA program and have put a number of graduates out, but we are a very new medical school. We're only about 6 or 7 years old. Because we're so new, we're able to develop our teaching methods and approaches on what research says is the best way to train clinicians. And actually, the research is saying that cadavers aren't the best way. Because when it comes to surgery, cutting into a cadaver is nothing like cutting into a real person that's alive. And when it comes to understanding anatomy, the cadavers are of limited use because there's only so much you can see. So they're based really on tradition. We don't use cadavers in the School of Medicine. Instead, we use those anatomy models that we talked about before. Pardon me. And we also use this Anatomage Table was actually based off real people, but rather than them donating their cadaver to be used for one dissection, they donated their body to be used for this program. So you can bring up real people of different genders, ethnicities, and ages. You can see the gross anatomy, and then you can use virtual dissection tools to peel away layer by layer. And that gives you a real understanding of the anatomy of the person. And obviously you can imagine then that this is a really good way to essentially reuse the same content repeatedly, rather than the person being able to be dissected only once. So the Anatomage Table is a very, very cool instrument. And we also have labs. Now, as you may have seen from the biography, I'm a cancer research scientist by background. So I have to plug laboratories and research anywhere I can. It's a moral obligation. As a physician associate student, you won't be spending a lot of time in the laboratory like this. However, you have the opportunity to do research in the summer or to take your degree further. So we do offer opportunities for people to train in the laboratory if they are interested. And again, this is just a snapshot from our clinical skills suite, where some of our students are practicing clinical skills on each other. So, about the staff, who's teaching you? So, any university is going to say this, but we like to think it's particularly true for us. We believe that we have enthusiastic expert staff. And if I've made you laugh even once in this entire presentation, then I consider this a complete success. So we have enthusiastic expert staff who are passionate about their particular disciplines. And we have people that are divided. Some of them are clinicians, some of them are pure academics, some of them are researchers by background. And that multidisciplinary team that we have really allows us to deliver excellent medical education to you all. During the 4-year program, you will be taught by a number of people, including research scientists, nurses, doctors, PAs, and so on. The core physician associate team is shown on this picture. So we have myself to begin with. I'm Emyr Bakker. And like I said before, I'm a cancer research scientist and a researcher. So I'll be teaching you all about cancer, all about research, and helping you to develop that critical thinking mindset that you really need as a clinician. Next on the PA team, we have Dr. Helen Davis, who is a medical doctor by background and primarily teaches in the last 2 years of the program. We also have Dr. Peter Dixon, who's a GP by background, probably for almost as long as I've been alive. So he's got a huge amount of clinical experience behind him. And a lot of his teaching is in the last 2 years as well, but you will see him in the first 2 years for some pathology lectures. Next up is Dr. Tia Helen, who is a researcher and academic by background. So her research interests are all about nutrition and diabetes and so on. So she, again, like myself, is going to help you to develop that critical mindset and help you to realize that just because something is published in a medical journal doesn't mean it's any good. Dr. Hazel Owens is another GP by background who's on the program. Again, she teaches throughout the 4 years and has a main interest in obstetrics and gynecology. The next 4 people are particularly exciting for you guys if you're training to become a physician associate, because these guys are our PAs. So Matt Mustaine and Dawn Sawyer have been PAs for decades from the United States. So they trained in America, which is where the physician associate role originated. They're known as physician assistants over there. Rachel Norris is our UK-trained physician associate, and she's just recently joined the team as a senior lecturer. Michael Ticchio is another physician assistant. I say assistant because he's American, so therefore he's called a physician assistant rather than associate. And his background's all in emergency medicine. Last up, and certainly not least, is the program director, Jane Rutt-Howard. She is an advanced care practitioner by background, and will teach you. She has a main interest in cardiology, but she'll teach you about prescribing and communication skills. And Jane, of course, feel free to say more about yourself in the chat, because I'm sure there's many more things to say about you. So, some of you might be thinking that all you need to do is get to the end of year 13, or the end of your schooling career, and then you're done. And that's true to some degree, because you get your qualifications and you go on to a degree. And then you get your degree and you earn a lot of money and live a very happy life. However, as you are entering a medical profession, whether you're becoming a scientist, a nurse, a doctor, a physician associate, you are committing yourself to a lifetime of lifelong learning. So you will be continually learning your entire life. And that's part of the privilege and interest of being involved in this field. So what is a physician associate? You may have heard of physician, which is essentially these days a synonym for a doctor. And you know that an associate is someone who associates with somebody. So what is a physician associate? PAs are medically trained generalist healthcare professionals. And they work alongside doctors to provide medical care as part of an integrated multidisciplinary team. PAs are what we call dependent practitioners. What this means is that they require a supervisory element to their role, such as a consultant or a GP that they can refer to. But this supervision doesn't mean that you don't have autonomy. There are still a huge amount of tasks that a PA is expected to be able to handle independently, essentially. But the generalist nature of their training means that a PA can change specialties. And as a result of that, they have that supervisory element. So they do work autonomously with appropriate support. And the idea is that a PA will supplement the medical workforce and therefore improve patient access. So one thing I would like to ask you is, if you're here at Health Careers Live today, that means that you have an interest in medicine. Can anyone tell me what the training pathway for a doctor is? How does it work? So Miriam has said 5 years of medical school, 2 years of foundation year training. So that's right. 5 years of MBBS, 2 years foundation training, and then however many years for your specialty training. Exactly, yeah. So you specialize as a doctor, and then it takes longer. So the specialty training, I believe, is anywhere from 3 to 7 years or more. So that is a long time. And the thing with being a doctor is that if you train in that pathway, you do your foundation years, you do your specialty training, and you become a consultant endocrinologist, for argument's sake. If you as a doctor then want to change the medical field that you work in and re-specialize, you would have to go all the way back to as if you had just finished your foundation year training and retrain. Okay? So it's harder for a doctor to switch specialties. And that is one of the key differences between being a doctor and being a PA. As a PA, you are trained to be a generalist. So this means that you do, in this case for MPAS, you do 4 years for your degree, you do the national exam, and then you're straight out to work. And if you decide that at first that you're interested in emergency medicine because you like the fast-paced nature of the job, fantastic, go and work in emergency medicine. However, after 5 years, you might realize that getting an adrenaline rush every 3 seconds of the day might not be the best thing for you. And therefore, you decide that you want to retrain or re-specialize and become a PA in general practice, for example. You can do that very, very easily as a PA. And some PAs will work 2 days a week in one medical discipline or field, and then 3 days a week in another, for example. So as a PA, you have that lateral mobility, which lets you switch which specialty you're working in. So it gives you that flexibility, which is what a lot of people as a PA value. So what do you do on a day-to-day basis? The role will include interviewing and examining patients. You will order tests, you'll interpret the tests, and make decisions about patient management. And really, the role is an exciting alternative to studying medicine and becoming a doctor. A lot of people are interested in the field of medicine, but maybe don't want to commit to the essentially decade-long training that a doctor has to undertake. Some of them would rather do a shorter degree and get out there sooner working. Once a PA is in post, they offer continuity and stability of care to the patients and also provide stability for their immediate healthcare team, because trainee doctors and surgeons will rotate through different specialties during the foundation year. And whilst the PA has the opportunity to work in different specialties just by virtue of their lateral mobility, when they're in post, they offer that continuity and stability. And a PA will be trained to and maintain their generalist expertise. The physician associate presence will also provide cover so that trainee doctors can attend training, clinic, or theatre. And I'm sure you know, but when I say theatre, I don't mean going to see Benedict Cumberbatch as Frankenstein. I mean theatre as in a surgical theatre. Doctors don't just get to go off and go to the theatre in the day. So this is what they look like. Our physician associates are, as we said, with this red or the burgundy scrubs. On the bottom left is the image we saw before of our physician associate students in West Lakes. And you can find PAs working in GP, accident and emergency, inpatient medical and surgical wards, and so on. And some may work in community clinics as well. On the bottom right, you have an image of some of our physician associate students learning clinical skills. In this case, they're learning basic life support. One of the cool things about enrolling on this program is that you will get a BLS and an ALS certificate. So basic life support, BLS certificate, and you'll also get an intermediate life support, ILS certificate as part of the program and extra training that you can undertake. So what do they do? As we said, so PAs will see patients with undifferentiated diagnoses. They will see patients with long-term chronic conditions. They'll take medical histories, carry out physical examinations, and perform diagnostic and therapeutic procedures. They will request and interpret diagnostic studies. For example, a lot of the things to measure homeostasis that we talked about in the first half are things that a PA could measure. PAs will formulate a differential diagnosis and an appropriate management plan. And they will provide health promotion and education to patients. Currently, physician associates are not able to prescribe or order ionizing radiation. And the reason for this is simply due to the lack of the legal regulation. So physician associates are a recognised role in the NHS, but they're relatively new in the UK. And they do not officially have a regulatory body yet, although there is an organisation called the Faculty of Physician Associates, which sits within the Royal College of Physicians, which acts as a kind of de facto body for the PAs. Now, once the PA profession gets legally regulated by the General Medical Council, which has been announced and is ongoing, we anticipate that physician associates will be able to prescribe and order this ionizing radiation. But the legal regulation is still ongoing because it's a new role. So again here, we've just got some images of our students observing a procedure and then performing the procedure themselves. One thing you may have noticed from the slide at the beginning was that we are looking at integrated masters. So what is an integrated masters? As the name suggests, an integrated masters is a master's level qualification, and they begin at undergraduate level, just like a normal bachelor's. But unlike a bachelor's degree, they continue for an extra year, or more in some cases, and successful students will then be awarded a master's degree. So integrated master's degrees are enhanced undergrad degrees, and they are increasing in popularity. So the numbers rose by 30,000 over a 4-year period. So they're becoming more and more popular. And the number of integrated master's science degree holders who are employed in graduate level employment or in further study is consistently slightly higher than BSc graduates. The other reason why we're looking at the integrated masters is to provide that parity with the postgraduate trained physician associate students and with other healthcare students. So the vast majority of physician associate training in the United Kingdom is at the postgraduate level. So you already have a degree, and then you do a 2-year master's. UCLan was the first university in the UK to develop this undergraduate physician associate training pathway. Other people are copying us now because we're the ones that come up with the great ideas. So we were the first to offer that 4-year program. And if you think back to other healthcare professions, such as pharmacy, they will be MPharm, Master of Pharmacy. A lot of nursing graduates will get a master's as well, and they will have their master's in nursing. So by having the physician associate course at a master's level, it gives parity, both with postgraduate trained physician associates and also with other healthcare providers. So what are the entry criteria? First is the A-levels. So if you're doing A-levels, you need to have 2 science subjects, including chemistry, a second science, and a third academic subject. It doesn't matter if your A is in chemistry or not, but you need to have that chemistry element. One thing that does set us apart, however, is that we don't require any GCSEs. And this is part of our drive for widening participation and widening access. I will add as well that if you are coming onto the physician associate course from a foundation year, then the normal entry criteria will be 65% overall on the foundation year, with 70% in specific modules. So if you are really keen on becoming a physician associate, but you don't have the right A-levels or you don't have the right A-level grades, you can study our medical science foundation year, and that will give you the academic criteria to train as a physician associate. So business or psychology, they should be fine, Miriam, as long as you've also got, psychology, as Jane says, is excellent. And we have a lot of people on the postgraduate program who've done a degree in psychology, and they use that to get on the postgrad. So psychology would be fantastic, Miriam. So as we say, if you don't have the right A-levels or the wrong A-level or the right A-level grades, then you can study a foundation year, such as our foundation year, and that will give you the academic criteria to apply for MPAS, although you still have to interview competitively. When you apply, you also need to include an academic reference. So you could say in your personal statement that you volunteered for 7,000 hours in community, for example, or in a GP. And that sounds impressive, but we would like any information you provide to be corroborated by your teacher, for example. with the academic reference. When you apply successfully, you're required to undergo a DBS check, a disclosure and barring services, or the international equivalent. And that DBS check, of course, is simply because as a physician associate, you will be privileged to work with vulnerable people. You also need to undergo an occupational health screen for your own safety and the safety of others before you enroll. And also when you apply, you will have a transferable skills statement, which is subject to change year to year based on current situations such as the pandemic. But we will weigh up your application based on your personal statement, transferable skills, and your reference. Now, the recruitment process is that you apply via UCAS. So anyone who's a UK student should know about UCAS, which is the Central University and College Admission Service. And that lets you apply for any undergraduate degree in the country. And usually you have 5 choices on UCAS. When you apply to us, we will review your personal statement, transferable skills statement, and your reference. If we deem these to be of a high enough standard, then the interview will take place either by a panel interview conducted remotely, or it could be through a multiple mini interview. So some of you may not be familiar with MMIs or multiple mini interviews, but these work on the basis of stations with individual examiners assessing a specific skill. So for example, if you went on to interview by an MMI, then you could have one station that assesses a scenario on medical ethics. You could have a second station that assesses your ability to interpret data. But the key thing with a multiple mini interview, at least with us, is that we don't require specific knowledge. As a biochemist and a pure research scientist by background, I would love to ask every applicant what the role of phosphofructokinase 1 is in the cell. Unfortunately, that's a specific knowledge element, so I can't ask that at the MMI. We have a series of standardized stations that simply assess how you approach a problem rather than do you know X, Y, Z. The other thing we're aware of is that when people apply for the physician associate course, the MPAS degree, a lot of people are doing so as a 5th choice for medicine. And that's understandable because we know that, one, there are only 2 universities in the UK that do an undergraduate physician associate course. So we understand that a lot of people will use MPAS as their 5th choice. If that's the case, that's okay. But just try to make sure that you mention somewhere about physician associates. So even if the majority of your personal statement is tailored towards the being a doctor, for example, just include somewhere about physician associates. You could say, for example, as a doctor, I will be working with the multidisciplinary healthcare team. This includes nurses, physician associates, pharmacists, and others. Just show us that you have that awareness of being a physician associate. So even if you use this as a 5th choice, that's okay. But remember that the PA course is competitive, and therefore just mention the physician associate and show an awareness of the role within that personal statement. So the Integrated Masters of Physician Associate Studies, as we said, it provides an exciting opportunity for undergraduates to become healthcare professionals in just 4 years. And you combine university with practical work-based placements. 50% of the final 2 years are spent in clinical environments. So you spend a huge amount of time in phase 2, which is the last 2 years, in placement. The overall aim of the course is to produce students that are trained to the highest educational and clinical standards, who, in a multi-professional setting, can succeed in providing safe, high-quality patient care that is consistent with the competence and curriculum framework for physician associates. The structure of the program is that in the first 2 years, you're taught alongside the MBBS medical students at UCLan. And that's essentially the first 2 years of medical school with slight variation. And we'll talk a little bit more about the variation as we get to it. In the last 2 years of the program, you're taught alongside the graduate entry, the postgraduate students studying the MSc in Physician Associate Practice. Before I talk about the modules, I will add the caveat that the university is currently going through the quality assurance and enhancement processes, because we continually review our programs to ensure that they're meeting the needs of our students and providing the best possible education. We're currently going through this process at the moment, so the modules are subject to change for people starting in September 2021 or later. The way the program is currently structured is that in year 1, you do a module called Integrated Science and Clinical Medicine, a second module called Evidence-Informed Practice of Medicine, and a third module called Medical Skills and Quality Care. So Integrated Science and Clinical Medicine, or ISCM, is really your science module, and it's presented thematically. So you start off with a core block that teaches you the fundamentals of the different disciplines, such as anatomy, physiology, biochemistry, cell biology, and so on. After that, you move thematically through the systems of the body. So you could start on a cardiovascular block, for example. You could then do a gastrointestinal block, a urogenital block, and so on. And that will teach you really all of the sciences applied to medicine. The second module that you do is Evidence-Informed Practice of Medicine. This considers things like epidemiology, which is disease on a population-wide level. And you can imagine, given our current circumstances, the key importance of epidemiology. It will teach you about biostatistics, and it will also teach you about the biopsychosocial model of medicine. And the biopsychosocial model of medicine is really about the idea that your patient is more than just a disease. We want you to think holistically. So don't just see them as, oh, they've got this disease, therefore they need this drug, and therefore that's all I need to do. Your patient is a person. They will have physical needs, they will have emotional needs, they will have psychological needs, and they will have social needs. So all of those are important to really understanding the course of a disease. The third module, Medical Skills and Quality Care, is all about your clinical content. And that's where you learn how to do a clinical examination, interact professionally, and so on. You also have an introduction to being a physician associate, which is where you learn more about the role. In year 2, you do Integrated Science and Clinical Medicine 2 and Medical Skills and Quality Care 2. And you notice that the module names are the same because we employ what's known as a spiral curriculum through the degree. So you revisit similar content as you move through the degree, but you look at it in more complexity and more detail. The variation from medical students is this module called Principles and Applications of Research. So that is a module exclusively for MPass students and not for medical students. And what this module will do is it will teach you all about research, ranging from cells in a dish right through to clinical trials. Year 3 is where it gets much more clinical. You spend 50% of your time on placement and 50% of your time at university. You also only have 6 weeks holiday each year. So it's like 2 weeks at Christmas, 2 weeks in the summer, and then 2 other weeks scattered about throughout the year. But that will teach you much more focused on clinical medicine, evidence-based practice, and also key clinical skills. And year 4 takes those same modules and again does that spiral curriculum where you revisit things in more complexity and more detail. And by the end of the program, you will be a fully fledged physician associate, which means that if I ever get into any trouble, you can look after me. So that's why I'm training you. Throughout the degree, we try to promote small group work to provide knowledge and interpretive skills and also improve your team working ability. This is primarily, it's throughout the degree, but more focused on this in the last 2 years. Because you study alongside medical students in the first 2 years, then there may be large numbers of students in lecture theatres for some of your modules, but there are small group work elements throughout the programme. And again, we'll teach you all about clinical history and examination. And we integrate the basic anatomy, which is the body in the normal state, with the applied anatomy, which is how it goes wrong in a disease. And just some more pictures from our students. I apologize for the slight rush. I think it's because I'm slightly over time. So we'll just whiz through the last few. So PAs can be found working in a number of different specialties. And currently, because of the demand for the physician associate role, there's probably about 100% employability as a physician associate. Most PAs will work in general practice or emergency medicine. But if you think of a branch of medicine, you can find a PA working in them. So it ranges from cardiology through to rheumatology and vascular surgery. But because of the generalist nature of their role, most physician associates will go into general practice or emergency medicine. And you can see that the majority of PAs will take a medical history or do a physical exam. The majority, again, will do patient education, venipuncture, EKGs, cannulation, arterial blood gases, and so on. And less commonly, they'll do psychiatric examinations, suturing, nanogastric tubes, and so on. Now, unfortunately, due to time, we don't have time to run through all of these, but you can see that there is a huge range of the possible roles that a PA can do. So I'll leave you with some closing quotes from our former students. So they say that when you're on placement, you're at a similar level to a junior doctor. You learn a lot during the degree. You do a clinical job, you're satisfying a patient need, and you're making sure they get the treatment they deserve. It's really fast-paced. Imagine medicine without the fluff. We support each other a lot, and we're like a family. If you want to learn more about physician associates, you can go to the Faculty of Physician Associate website, the www.fparcp.co.uk. And if you have any questions, you can get in touch with Jane, who's the course leader, and myself as the deputy course lead. We are also going to be here all day on the exhibition stand. So if you click on the exhibition link and then you go through to the, and you scroll down, you'll find one from the University of Central Lancashire about physician associates. So we'll be about for the day and able to answer any questions. But that is my last slide for the presentation. So I'd like to thank you all very much for your attention. And I'd like to apologize to the hosts of the event for running over by 3 minutes. But thank you very much, guys. It's been a pleasure.